Is your gallbladder trying to kill you? Hi, it's Dr. Pan here. Let's talk about the complications of gallstones. If you want to learn about the fundamentals of gallstones first, please check out the link below. The most well-known complication of gallstones is cholecystitis. Cholecystitis is the inflammation of the gallbladder. It occurs in 10% of patients with gallstones, which equates to an overall population incidence of 1%. The underlying pathophysiology of cholecystitis involves an obstructing gallstone, which obstructs bile flow, leading to gallbladder distension, gallbladder wall edema, bile salt irritation of the gallbladder wall, and inflammation of the gallbladder. Once inflammation occurs, there is increased venous stasis and endothelial injury, leading to microvascular thrombosis and ischemic necrosis of the gallbladder. During this process, the gallbladder may also become secondarily infected. Common organisms of infection include Escherichia coli, Klebsiella, Enterococcus, Enterobacter, Streptococcus, Pseudomonas, and Proteus. This pathway of gallstone-induced cholecystitis, also known as acute calculous cholecystitis, accounts for over 90% of causes of cholecystitis. The other 10% of cholecystitis is from acalculous cholecystitis, which results from biliary stasis and gallbladder ischemia in absence of gallstones. This occurs in critically ill patients, typically in an ICU setting. Patients with repeat biliary colic attacks can also have a histological finding of chronic cholecystitis on the histology specimen following resection. This include histological findings of inflammatory cells and Rokitansky-Ashkov sinuses, which form due to gallbladder wall weakening secondary to repeated obstruction and gallbladder contractions against resistance. Complications of cholecystitis include gangrenous cholecystitis, emphysematous cholecystitis, and perforated cholecystitis. The symptoms of cholecystitis include upper abdominal pain, nausea, and vomiting. Signs include fevers, tachycardia, and the presence of Murphy's sign, which is pain on palpation of the right upper quadrant of the abdomen during deep inspiration. Patients with complications of cholecystitis will also develop peritonitis, which manifests as rebound tenderness and percussion tenderness. As the names suggest, rebound tenderness is pain on release of palpation when the abdominal wall rebounds back, and percussion tenderness is abdominal tenderness on percussion. Investigations include blood tests and imaging. Relevant blood results would include a raised white cell count and C-reactive protein. The most useful imaging modality is an abdominal ultrasound. Findings of cholecystitis on ultrasound include gallbladder wall thickening to greater than 4 mm, gallbladder wall hyperemia, tenderness on probe pressure, and pericholecystic fluid or stranding. A CT scan is often performed to assess for abdominal pain, but is not as sensitive or specific as an ultrasound. CT findings include gallbladder wall thickening to greater than 4 mm and pericholecystic fluid or stranding. Occasionally, if there is any diagnostic dilemma, cholecystography or a HIDA scan may be performed. This involves the injection of technetium-labeled hepatobiliary iminoacetic acid, or HIDA, which is taken up by hepatocytes and excreted in bile. This is normally taken up by the gallbladder if the cystic duct is patent, so the absence of gallbladder uptake suggests a blocked cystic duct or cholecystitis. The treatment for cholecystitis can be operative or non-operative. Regardless, all patients should be treated for sepsis with intravenous fluids and broad-spectrum antibiotics with anaerobic coverage. Operative candidates should have a cholecystectomy, which can be performed using laparoscopic or open techniques, depending on the patient and clinical situation. The evidence suggests that patients with cholecystitis symptoms for less than 7 days should have upfront cholecystectomy, while those with symptoms of greater than 7 days should have non-operative treatment first, and then a delayed cholecystectomy after 6 weeks, when the inflammation settles. Non-operative candidates should have non-operative treatments, which is continued antibiotics with or without a transhepatic cholecystostomy tube, which is used to drain bile from the obstructed gallbladder. Another complication of gallstones is choledocholithiasis, or a stone stuck in the bile duct. This occurs in 10% of patients with gallstones, which equates to a population incidence of 1%. While stones can form in the bile duct even without stones in the gallbladder, known as primary choledocholithiasis, the majority of cases are due to stones migrating from the gallbladder, known as secondary choledocholithiasis. The symptoms and signs of choledocholithiasis include right upper abdominal pain, jaundice, dark urine, light stools, and pruritus. Investigations include blood tests and imaging, with blood tests showing deranged LFTs and raised bilirubin. Imaging modalities include ultrasound, CT, and MRCP, all of which can be used to assess the bile duct diameter and presence of any stones in the duct. MRCP is the most accurate, with a sensitivity and specificity both of 95%. The treatment will involve clearance of bile ducts and removal of the gallbladder to prevent further episodes of choledocholithiasis. These procedures can be performed separately, in either order, or concurrently depending on the patient and institutional factors. A concurrent procedure of cholecystectomy with clearance of the bile duct requires a cholangiogram to assess the bile duct and may involve the following techniques to remove the stone. 1. Saline flush to flush stones through the sphincter of Oddi into the duodenum. This may be augmented with the use of intravenous buscopan 10 to 20 mg or glucagon 1 to 2 mg, both of which help relax the sphincter of Oddi. This technique is best with small stones. 2. Stone retrieval with a transcystic basket. This involves using a retrieval basket under fluoroscopy to pull the stone out of the bile duct via the cystic duct. This technique is best used in the context of solitary stones and a dilated cystic duct. 3. Transcystic choledocoscopy and stone retrieval. This involves inserting a choledocoscope down the cystic duct to visualize the stones obstructing the common bile duct. These stones can then be retrieved with a retrieval basket under direct vision. This technique is best for solitary large stones and a dilated cystic duct. 4. Anterograde sphincteroplasty. This involves using a CRE balloon catheter inserted anterograde down the cystic duct to expand the sphincter of Oddi, then pushing the stone through the distal end. This technique has higher risks of injury to the sphincter of Oddi. 5. Choledochotomy. This involves making a longitudinal incision in the bile duct, retrieving the bile duct stone, and closing the original incision. This procedure can be used to remove larger stones, but should only be performed at hepatobiliary centers due to greater risks of bile duct injury. 6. Subsequent endoscopic retrograde cholangiopancreatography, or ERCP. If the stone cannot be removed, the gallbladder should still be removed first, and the patient be committed to a subsequent ERCP. An insertion of a transcystic stent through the sphincter of Oddi can be performed first to decompress the bile duct and make subsequent ERCP easier. Of course, if there are any concerns, an ERCP can also be performed first to remove the stones, and then perform a risk-reducing cholecystectomy afterwards. Choledocholithiasis itself can also cause further complications, the main one being cholangitis, which is sepsis secondary to an obstructed bile duct. Cholangitis occurs in 10% of people with choledocholithiasis, which equates to a population incidence of around 0.1%. although cholangitis is commonly caused by stones, it can also be caused by benign strictures, malignant strictures, and ERCP procedures. Common organisms involved in cholangitis include Escherichia coli, Klebsiella, Enterococcus, Enterobacter, Streptococcus, and Pseudomonas. These bacteria can translocate from the bile duct into the portal vein due to increased pressure in the biliary system. An obstructed bile duct also causes bile stasis, which in addition to the presence of any stones, further act as a nidus for bacterial growth. Patients with cholangitis present with Charcot's triad, which is right upper quadrant abdominal pain, fever, and jaundice. In severe cases, patients present with Raynaud's pentad, which is right upper quadrant abdominal pain, fever, jaundice, hypotension, and mental status changes. The investigations used are the same as for Choledocholithiasis. Blood tests will demonstrate a raised white cell count, C-reactive protein, bilirubin, liver functions, and positive blood cultures. Imaging will demonstrate an obstructed bile duct with inflammation around the duct. Treatment will be the same as treatment of sepsis, which involves fluid resuscitation, broad-spectrum antibiotics with anaerobic coverage, and support of any end organ dysfunction. Specifically, patients require urgent decompression of the biliary system, either with an ERCP plus sphincterotomy and stent, or percutaneous transhepatic cholangiogram, PTC, and stent. It is important to treat patients early because cholangitis is a serious condition and has a mortality rate of 5 to 10%. Obstructing stones can also block the pancreatic duct and cause pancreatitis, but I will cover that in an upcoming pancreatitis episode. Thank you for watching. If you like this video, please like, subscribe, share, and comment for more videos.